Hello, my name is David Chandler Thomas, a professor of economics at Ball State University in the Midwest. Prior to becoming a professor of economics, I spent 25 years in Silicon Valley as a high-tech CEO and startup entrepreneur. During that time, I was able to work on solving complex problems with the help of many very intelligent people. After my time in Silicon Valley, I spent 5 years in Washington, D.C. as the executive director of the Software Industry Association. While there, I worked with the legislature, with lawyers, and with lobbyists, and learned firsthand how the political monopoly works. Upon the completion of my assignment in Washington, D.C., I returned to my education, earned my Ph.D. in economics, and again with the help of some very smart people, was awarded a tenure-track position here at Ball State University. I'm also married, the father of 5 children, and the grandfather of 10 grandchildren. I mention this because it's important to understand what my incentives are. I want very much to make the world a better place for them. You know, we Americans love to have the best. And I have to tell you that on one hand, we have the most amazing and absolute best healthcare system in the world. On the other hand, we have the absolute worst health insurance system in the world. The only thing that's even close to being as bad is the single-payer system, which they have in Europe and we have here in the United States at the Veterans Administration. If we were to adopt the single-payer healthcare system that they use at the Veterans Administration, or something similar to it, we would see the world's best healthcare system deteriorate over time and become one of the worst healthcare systems in the world. On the chart you see behind me, the United States expenditures on healthcare are 17.1% of GDP. And remember, we're the richest nation in the world. The other nations on this chart are the developed nations, and most of them have longer life expectancies than we do, and yet they're spending far less as a percentage of their GDP. This can be translated in dollars that we understand. First, that translates into $9,300 per man, woman, and child every year. And yet, our life expectancy, which is across the bottom of this chart, is lower than most of the other developed nations. So we're really not getting our money's worth, are we? If we were to have an efficient insurance system so that our consumption of healthcare was proper, we would save about $5,000 a year for every man, woman, and child. That number is bigger than the GDP of most nations in the world. And so we have this paradox, because on the one hand, we have the greatest healthcare system, and on the other hand, we have the worst health insurance system. Prior to World War II, medical insurance in America was very simple. People purchased classic, catastrophic health insurance and paid for the rest out of their pockets. During World War II, our best and brightest young men and women were drawn up by the government to be used in the war. Many factories were forced to participate in the production of weapons and munitions, and stores of our natural resources were consumed to help in the ramp-up of the war machine. Any good economist will tell you that when there is a scarcity of a good or service, prices rise. And so it was that prices began to rise for materials, products, and people. The American people expressed their unhappiness at the ballot box, and Congress responded like they usually do, with a solution that was not optimal. Their solution was just fix the prices. And they did. They created a special government agency, and this agency put thousands of people to work, creating lists of every product, every raw material, and every job in America. And they put these lists together and assigned prices to them, and then they said, if you don't follow this price, you will be fined, or maybe even put in jail. The American economy was forced to operate with fixed prices. Again, any good economist will tell you, if you constrain the price ceiling, you're going to have shortages. And so we had shortages of materials and products and labor. People were required to have coupons to purchase the food they needed just to feed their families. Well, some of the entrepreneurs came up with a very clever idea. They told us we couldn't pay higher wages, but they didn't say we couldn't offer greater benefits. And so they started offering healthcare benefits in the form of medical insurance. This caused their competitors to say, well, I guess we'll have to do so too. And before too long, most of the employers were offering healthcare benefits as a way to compete in the marketplace. Now, when the war ended, the workers and the employers said, hey, we like this. We get a portion of our wages without having to pay income tax. And they thought it was a wonderful deal. But there was one group that did not think it was wonderful, and that group was the Internal Revenue Service. And so they started taking action against the business owners and their employees. And of course, this was a strategic mistake because these are the voters. So the voters contacted their political representatives and they said, "Stop this. They shouldn't be doing this to us." And the response was no problem. And they codified the third-party payer system and made it law so that employers could pay benefits in the form of healthcare as a pre-tax benefit. And that is how we got the third-party payer system. Prior to the third-party payer system, if a patient was sick or hurt and they needed a doctor, they would search out among the various doctors and hospitals and negotiate on a price they thought was reasonable for the quality of health care that they were receiving, and then they were done. And so we had an efficient market solution that worked. But it did mean that some people didn't get the health care they required. And so it was left to churches and other service organizations to step in and help. Over time, some of the procedures became more expensive, increasing the demand for health insurance. Patients began to purchase catastrophic health insurance, just in case they had something like heart disease or cancer, and the expense was going to bankrupt them. When the third-party payer system emerged, the employers joined the game. And this meant that the employers paid a lower wage to the worker and took that money to cover the cost of insurance premiums, turning the insurance company into the customer. And the patient experienced what they thought was subsidized care. The insurance company added up all of their expenses and then adjusted the premium to the business owners. This model destroyed the market system and the price system. The patient no longer had any idea what the medical products and services they were ordering really cost. Now, I liken our health insurance system to the legendary Gordian Knot. In the ancient town of Lycia, a chariot had been tied to the temple of Zeus by Gordius, the peasant-made king, using a magnificent and complex knot. A local oracle had prophesied that the one who untied the knot would be the rightful ruler of Asia. Well, one day Alexander the Great came to town, and when he heard about this prophecy, he went to the temple of Zeus. After studying the Gordian knot and attempting to untie it, Alexander discerned that the materials they had used and the way the ends were tucked up inside the knot made it impossible to untie. And so Alexander stood up, he pulled his sword out of its sheath, and in one swoop, he sliced the knot right through the middle. The remnants of the knot fell in pieces on the ground. Alexander pronounced that he had in fact untied the knot. It is written that Zeus was so impressed with both Alexander's willingness to act and his clever mind that he gave him Asia to rule. Now, this is a story about complexity and how sometimes a complex problem can be so difficult to solve, the only viable solution is to just cut it through the middle, to just open it up and get rid of it. I think we can safely say that our health insurance system is just such a Gordian knot. So let me describe in greater detail what this knot consists of and why it's so complex. First, we have the complex problem of adverse selection. Adverse selection is an insurance and economic term that means those needing insurance the most are the ones most likely to buy it. For example, if you get a call from your doctor saying that test results indicate you likely have cancer, you will suddenly have a great interest in having health and life insurance, and you might jump on the phone and call your agent. "I'd like to buy some of that life insurance and health insurance you've been trying to sell to me." Now, the insurance companies know this, and they use a concept they call pre-existing conditions. Insurance agreements refuse to cover any serious conditions existing at the time you purchase your policy. While this solves the adverse selection problem, it means some of our most at risk go without insurance. Adverse selection was what President Obama and his MIT economists were trying to solve. They thought they had come up with a simple solution: use the power of the government monopoly to force everyone to have insurance. If everyone's insured, the problem goes away, right? Sure, healthy people pay higher premiums, but Obamacare simply penalized anyone unwilling to pay. The solution was a valiant effort. Unfortunately, in their effort to deal with the adverse selection complexity, they brought 30 million more Americans into the worst insurance system in the world, making the knot bigger and even more complex. The second element of complexity consists of what we call moral hazard. Moral hazard means any change in your behavior resulting from insurance against risk. I once tried to teach moral hazard to my youngest daughter by pointing out that because her car has seat belts, she drives less carefully and is more likely to be in an accident. Her response was, "Daddy, I don't drive less carefully. I'm a very careful driver." And she is. Those things have no impact on me. And so I asked her, if I put a steel spike in the middle of your steering wheel aimed at your chest, would you drive more carefully then? Now, I often present this scenario to my college students. They typically say, "Oh, you're right. I would drive more carefully." But my youngest daughter had a different answer. She said, "Daddy, I wouldn't drive at all, not with a steel spike coming out of my steering wheel." Nevertheless, there are a whole slew of examples of moral hazard in our health insurance system. The third area of complexity is the subsidy problem. Now, the subsidy problem is very simple. If something is subsidized, people will want to buy more of it. As a college student, if your parents offered to subsidize the purchase of a new car, such that you would only have to pay $1,000 of the cost, you might as well forego the Volkswagen for a Lamborghini because you're paying $1,000 either way. My wife called me one day from home with news that our youngest daughter, the one on the spike, had scraped her leg. It's a big scrape. What should I do? Relying on some of my first aid training, I said, "I think you should wash it with soap and water and put a bandage on it." Well, she said, "I would like to take her to the doctor. I would feel better. And besides, it's only $10. So off they went to the doctor. The doctor looked at it and billed the insurance company $120. Next, he said, "I think we should get an x-ray." My wife, unsure if that was a good idea, called me. She said, "Hey, the doctor wants to get an x-ray." I was incredulous. "What? It's only a scrape." She said, "I know, but he just wants to be careful. And besides, it's only $20. This story helps to illustrate the subsidy problem, but the recommendation to get an x-ray exposes the fourth element of complexity in our knot. This complex problem is advisor-induced demand. This problem stems from the trusted advisor relationship we have with our doctor. A doctor has two incentives for wanting to induce demand. The first is that they took an oath to do no harm. Therefore, they are going to recommend any service or product that might possibly make a difference. But secondly, they're also concerned about malpractice lawsuits. Malpractice insurance is the single biggest expense a doctor has. And if they get sued, it becomes even more expensive. This is another example of moral hazard. One of the ways they avoid being sued is to overprescribe healthcare. And so our doctor thought, well, she doesn't really need an x-ray, but if there's even the slightest chance that she does, we should probably do it. And because we trust the doctor and because the cost was subsidized, we do. But sometimes the doctor is not just acting as our advisor, but also a supplier. And if the doctor is our supplier, then we have both advisor and supplier-induced demand. This is a very common thing. For example, if you take your car into a local dealership and they inform you that you need a new $5,000 transmission, your initial reaction might be, well, that's a lot of money, and the dealership will directly benefit from what they're recommending. So if we are wise and recognize this problem, we take the car for a second opinion. And when we ask for that second opinion, we say, you are not going to be the one benefiting from the repairs on this car. I'm paying you for a second opinion. Now that auto repair person, or in our case, that doctor, has no incentive but to give you the right information. And so advisor and supplier-induced demand are very complex problems. Another complex part of the Gordian knot is the free rider problem. The term free rider comes from an earlier era of city trolleys. These trolleys had places where people could grab a hold on the outside, and many people would run up and grab a hold just as it was pulling out. They would hang on, ride a few blocks, and then drop off, not have to pay for the ride. The people on the bus who had purchased the pass would see them, and they'd be, hey, look at all those free riders. They're not even willing to pay for a public trolley ticket. Well, we have free riders in our healthcare system today, and there are lots of people who are upset about this. Finally, there's the complex problem of positive externalities. A positive externality occurs when the producer of a good or service does not internalize the full benefit of their production. This happens with immunizations. Getting an immunization is costly for me. I put myself at risk from infection, from allergic reactions, and other issues. But do I get the full benefit from my immunization? No. In fact, I get no direct personal benefit. The rest of society benefits as I add to the herd immunity. If I am one of only a few who do not participate, the benefits remain, but I have no cost. These are the complexities that make up the Gordian knot of American health insurance. These are kept in place by the third-party payer system, which combines all health insurance into one big knot. I'm a believer in market. I have participated in markets, and I've seen how competition from a variety of different producers, given the right amount of regulation, can result in the most efficient, innovative idea coming forward. When I was a CEO in Silicon Valley, many people probably wondered if I was greedy or trying to make a lot of money. And the answer is, well, of course. That is why I invested so much of my time and money in the first place. And then I discovered this great paradox. In my pursuit of profit, I was consumed from morning until night, 7 days a week with one thought. How can I make my customers happier? How can I produce a better product for a cheaper price and provide amazing customer service to make my customers happier? In contrast, within the bureaucratic departments of the central government, they have no incentive to think about their customer. How do I do exactly what I have to do with the budget I'm given? I have no incentive to spend any more time trying to come up with a better solution or to lower the costs. Our founding fathers had a brilliant idea. Let's create a political marketplace. Let's minimize regulation and governance at the central level. We can focus on protecting civil rights and on securing borders. Everything else should be delegated to the states. Why? Because it creates political competition. If my state doesn't act appropriately and my taxes get too high, if I'm unhappy, what can I do? Well, I could gather up my things and move to another state. Ultimately, we should leave the solution to our healthcare crisis and other important policy programs to the states, maybe even the counties. I feel compelled to make an important statement on American altruism. In America, we care about those who are less fortunate. It has always been part of our basic value system. We go out of our way to allow people to be free riders, and we seek to provide for the poor. This is a good thing when we consider what it means to the soul of the American people, but it can also be very, very costly. Still, any serious policy proposal must provide for those who are less fortunate. It is difficult to imagine a solution that is compatible with both our good desires and the principles of economic efficiency, but it can be done if we are both careful and clever. While employees, patients, and employers will find the solution I am about to propose significantly less expensive and more flexible, insurance companies will see this as a threat to their very existence. If this proposal is ever seriously considered for implementation, the dramatic drop in healthcare consumption will threaten the profits and power of providers and politicians. This proposal begins with a slice right through our insurance system, much like Alexander did to the Gordian Knot in Lycia. We cut the third-party payer system into 4 manageable parts. Once cut down and simplified, we can begin to address the complex issues of adverse selection, moral hazard, subsidies, free riders, advisor and supplier-induced demand, and positive externalities. We swing our sword with the Gordian Knot of the American insurance system, and the first slice falls off the knot. Catastrophic insurance. Now, catastrophic insurance provides coverage for those expensive, long-term, life-threatening conditions. Things that are not critical or emergent right now, but are critical over the long run. Things like cancer and heart disease. These can be very expensive, and they meet the 3 criteria for an insurable event. Unpredictable by the individual, predictable actuarially by the insurance companies, and very expensive. The fear of catastrophic health issues are behind the adverse selection problem. Now, we can apply the Obama-MIT solution effectively. On a state or county basis, we can require business owners to purchase a very low-cost, catastrophic policy for all employees and increase the unemployment insurance by a few dollars to provide for those out of work. Now, if the only insurance you have to provide for your employees is catastrophic, with a deductible of, say, $2,000 per incident and a cap of something like $200,000 per incident, the premiums are incredibly inexpensive. Plus, you're only providing this coverage from cradle to 65, because at 65, the federal government takes over with Medicare. We're talking about $100 a month per person or less. But you say, Dr. Thomas, what happens to the people who aren't residents of our state? What if somebody's visiting from New York and they have cancer? And the answer is, they have some time to go find a good doctor in a hospital in New York. Of course, if they have the money to pay, I'm certain our local hospitals and doctors would be happy to treat them. Here then is the tally so far. And now the second piece comes falling off the knot. Emergent care. Emergent care consists of those medical conditions that put us in imminent danger. Heart disease might take our life in months or years, but a heart attack is life-threatening now. With emergent care, it doesn't matter whether you are from France, New York, or Mexico. You need treatment now, and usually that means a trip to the ER. Emergency rooms are where we see the biggest free rider problem. Because of our altruistic nature, we are not going to turn away a truly emergent case. I have spent a lot of time in emergency rooms, and I have observed that most of the patients waiting in line do not have emergencies. They have back pain, or they have hurt their arm. These are not emergent life-threatening events, and they don't require a visit to an emergency room. If your house is on fire, you call the fire department, and they come and put it out. They don't care about insurance, and they don't send you a bill. If you have burglars in your house, you call the police. They come out and take care of the burglars, and they don't send you a bill. 911 handles two of these three. It ought to handle all of them. But how would we pay for this? In the same way it pays for fire and police, it's paid through property taxes. If we offer excellent police and fire services, visitors feel safe from danger while spending money in our community. Our property values are higher when visitors feel protected from medical emergencies as well. But this can also be expensive. So how do we manage the costs? To begin with, we should eliminate the outside entrance to the emergency room. No one should be able to just walk in, even if they're standing outside the emergency room only 20 feet away. We can have a phone there where they can speak to a 911 dispatcher, who then asks, what's the matter? And if you say, there's a burglar in my house, they'll send the police. If your house is on fire, they send the firefighters. And if you're in a medical crisis, when that is life-threatening, they send the EMTs. This is about triage, or in other words, prioritizing. Reporting that you think the plumber stole your wedding ring from the kitchen counter is not the same as having burglars in your house right now. Calling a report of a cat high up in a tree is not the same as a fire in your kitchen that won't go out. Calling to report back pain or a bruised arm is not the same as being in the throes of a heart attack or childbirth. Secondary triage is performed by the EMTs on site. They are there to stabilize and then determine the next level of care. If, for example, you cut your arm, do you really need to go to the ER, or can the EMTs help? You might get by with a few stitches. On the other hand, if you're having trouble breathing, they might put you on oxygen and transport you to the hospital. That would be determined by the EMTs. This approach will eliminate the majority of emergency room visits and costs. And here's where we are now. The next piece that comes falling out of the knot is routine care. Now, routine care consists of reasonably low cost or optional treatments. Because the extent and level of these treatments can be determined by the patient, routine care is subject to the moral hazard, the subsidy problem, and the induced demand problems. If patients are required to pay for routine care out of their own pocket, they will have to negotiate with the doctors and hospitals to get the best service for the dollar and choose less service. When my oldest son was in business school, he discovered a large and painful lump on his leg. He had previously had a bone tumor in one of his legs, so he went to see the doctor. The doctor was almost certain the problem was a non-threatening hematoma, but thought it might be a bone tumor. He pressured my son to get an MRI. Because of his deductible, the cost was going to be $500 out of my son's pocket. He called his dad for advice. I suggested he ask the doctor what would happen if he waited 2 weeks in each scenario. The doctor told him that if it was a hematoma, it would mostly go away. And if a tumor, it would not. But the risk from waiting was minimal. My son didn't even call me back. But you ask Dr. Thomas, what about those who are less fortunate, don't have money for these kinds of services? There should be a no-cost county clinic available where the unemployed or unemployable can go for treatment. These people might not have money, but they are rich in terms of time. The county clinic should operate much like the DMV or BMV. When people arrive, they take a number to see a doctor. So the idea is that those who have money pay for it out of pocket or from a health savings account. And those who don't have money pay for it with their time. But you ask Dr. Thomas, how do you keep those who have money from going to the county clinic? The cost keeps them away. If somebody has a job, if somebody has income, they don't want to lose wages while waiting in the county clinic. And here's where we are now. The fourth and final piece that comes falling off of the knot is preventive care. Now, preventive care comes in two forms, individual and societal. First are those services that help protect you as an individual from a potential catastrophic issue later. This would include things like mammograms for breast cancer and colonoscopies for colon cancer. Now, these could be fairly expensive, but we're still talking about only a few $100s. And all catastrophic insurance providers pay for these services according to a schedule. So then that's taken care of. Societal preventive care can be a great benefit to society as a whole, but not necessarily to the individual. Immunizations are a good example. I don't like to be immunized because I don't like needles, and sometimes there are side effects. I don't want to go through the immunizations, but I certainly do not want to pay for them. Society gets the benefit from the herd immunity. Societal preventive services should be subsidized by society because it is society that gets the benefit. So that's it. We solved the adverse selection problem now because everybody's insured. We solved the free rider problem by isolating it to the emergency room. We solved the moral hazard subsidy and induced demand problems by making people pay directly for routine care. And the positive externality problem is dealt with by paying for everybody to participate in the immunization process. And so we found a way to solve all the problems we currently face and still provide for the unfortunate by providing incentives for everybody to be as efficient and appropriate as possible in their consumption of health care. We cut our Gordian knot into 4 manageable pieces. Catastrophic care is to be provided for all residents in the state or county and paid for by employers. Emergent care, it covers everybody no matter where they're from and is paid for by property taxes. Routine care, covered out of pocket by those who can afford to negotiate the best prices with providers, and free at county clinics for those who don't. Finally, individual preventive care is part of the premium for catastrophic, and societal preventive care is paid for by taxes.